comprehensive primary care CPC initiative worked to improve care, improve health, and lower costs for patients and their families in the primary care setting. Nearly 500 primary care practices and more than 2,000 practitioners were enrolled in CPC from 2012 to 2016. The CPC initiative focused on 5 functions of primary care: access and continuity, planned care and population health, risk-stratified care management, patient and caregiver engagement, and coordination of care across a medical neighborhood. This on-demand learning series explores how CPC practices implemented strategies designed to strengthen primary care.
We'd like to start off our presentation today with Dr. Jeremy Bruce and Jeff Fawcett from the Christ Hospital Health Network.
As many of you know, we get a lot of patient-level data related to your practice. We wanted to try to look at that data and see what we could learn from it. So we took the data from the last quarter of 2014, covering a little over 7,500 Medicare patients that are part of the CPCI and our 16 offices. In looking at the data, learned that patients who regularly see their primary care provider had a lower total cost of healthcare and lower specialist healthcare costs. Looking at one of our offices, and we noticed that there was a highly correlated inverse relationship between spending on primary care and total healthcare costs. As the percent of spending on primary care increased, the total dollars spent on healthcare decreased exponentially. The data across all of our offices correlates strongly with each other. The first office we looked at was non-anomaly. We then wanted to see what the impact of primary care involvement had on 5 ambulatory care sensitive conditions. These are the 5 we looked at. Today we want to focus on congestive heart failure and COPD, but we will tie together the impact on diabetes, hypertension, and hyperlipidemia. We took the CMS data, combined it with data from our EHR, and looked at the impact of primary care on congestive heart failure related cases. In this graph, the blue bars represent patients with a diagnosis of congestive heart failure and possibly one or more of the other identified ACSC conditions. The red bars are patients without a diagnosis of CHF, but again, simply having one or more of the other identified ACSC conditions. And we wanted to, one, by looking at the difference between the red and the blue bars, see if we could isolate what the related cost was to a diagnosis of CHF. And then what we noticed between the 2 blue bars and the 2 red bars is the bars on the left are patients with no PCP contact. So you'll see that your CHF positive patients with no PCP contact had an average cost per patient per month for the period we studied of a little over $2,800. Patients that had primary care contact, that had similar HCC scores, the difference in these HCC scores is not statistically significant, had an 88% decrease in average cost of care per patient per month by including PCP contact. We did the same analysis on our COPD patients. Again, the blue bars represent patients with a diagnosis of COPD and possibly one or more of the other ACSC conditions. The red bars are patients without a diagnosis of COPD, but possibly having one or more of the other identified ACSC conditions. And again, you can see the difference. Patients with COPD, but no PCP contact during the period, had an average cost per patient per month of $1,669. Patients that had contact with their PCP had an average cost of $283, representing an 83% decrease in the average cost of care per patient per month through the involvement of PCP contact. So first we looked at the percent of healthcare costs spent on specialist care in relation to the number of primary care visits. we noticed an associated decline in specialist spending where primary care was involved in the patient care. Again, this is our study population of 7,500 plus patients. So patients that had 4 to 6 primary care visits were spending 17% of their healthcare dollars on specialists versus patients with no primary care visits spending 34%.
Our goal is to both increase the amount of contact that patients have with the PCPs and then bring primary care level care to the patient and to overcome logistic barriers to that. And we feel that the logistic barriers are either caused by the acuity of the patient's underlying condition and then the classic problems of finance and transport. So what we're doing is we're developing a protocol by which we're going to have home nurse visits according to a very strict protocol that we've outlined. And roughly, it's going to have a combination of clinician-guided congestive heart failure home visits and some patient education, and then a great deal of case management contact and really trying to make that contact happen and try to avoid exacerbations before they occur. So we use the multidisciplinary model, and we do a combination of patient interview with the physician direction of the care, nurse reinforcing that, and then follow up on the phone. And I think having more than one person involved, having more than one discipline involved, that is, doctor and nurse, and having more than one modality involved, I think is remarkably effective. And that is the next step, I think, that we're going to be taking in our research. So as we look at this data set, the thing I'm going to be doing is trying to figure out exactly where the visits as they were, but that's going to be really difficult. And the other thing we're going to be looking at is the presence or absence of case management, and then the amount of cost in a subsequent period and the amount of dollars sent to the practice. And my hypothesis is actually that these projects, like this comprehensive primary care project, actually is going to save a great deal of money. I believe it will. And that the most effective mode for doing that is going to be through case management, and that I actually think that the primary care practices are actually going to be making more money as a result of this kind of comprehensive approach to the patient. It's going to keep dollars out of catastrophes and push dollars into classical care.
For more information and resources, visit the Comprehensive Primary Care Initiative webpage. Go to innovation.cms.gov and search for the CPC Innovation Model. This has been a production of TMF Health Quality Institute.